Yeah,
Okay.
already can. Yeah.
Okay, sure. So, so very good afternoon, ladies and gentlemen. Thank you for joining this next installment of Infovax. This is an awareness initiative for healthcare professionals, amongst other parts of the campaign that we're running, and it's designed to help us out with healthcare professionals getting to know what are the critical insights and updates pertaining to COVID-19, especially in terms of vaccination, and how do we communicate that to patients. So in line with that, this afternoon, we're very privileged to have two very eminent speakers to speak about a very important topic. I think which already we have received quite a few queries about. So it's a very timely session and on a very timely topic as we roll out vaccination to the general population under this phase. This afternoon, we're very privileged to have with us Prof. Dr. Kartini binti Rahmat, consultant radiologist with the Department of Biomedical Imaging, Faculty of Medicine, University Malaya Medical Center. And we also have with us Professor Dr. Nur Aishah binti Muhammad Taib, consultant breast and endocrine surgeon, as well as the head of the University of Malaya Cancer Research Institute, Faculty of Medicine, University Malaya Medical Center. So thank you both profs for joining us this afternoon. Really a privilege for us to have you all with us. And especially as well, ladies and gentlemen, thank you so much for joining us as we speak about this afternoon's topic. Um, and just a little bit of housekeeping as we start up the sessions. As you all know, the sessions are people who are in the session in the Zoom. So go ahead and be on the Zoom. For those who are watching us on FB, just don't forget that at the end of the session, we'll put up the QR code for you to scan for your CME points. Yeah. And subsequently, the video and the session will be available on the MMA FB page, the YouTube page, as well as on University Malaya's respective social media channels as well. So this afternoon, both these eminent speakers will be sharing with us insights and updates pertaining to cancer screening and COVID-19 vaccination. So without further ado, please allow me to call upon the first speaker, Professor Aishah, who will speak to us in general about cancer screening and COVID-19 vaccination, as well as specifically on the areas of breast cancer, because we've had quite a lot of queries pertaining to this as well. Prof, hi, good afternoon.
Hi, Murali. Good afternoon. Thank you for inviting us. I think a lot of our patients and also doctors are a bit worried about what to do with our cancer patients during the COVID-19 vaccination rollout. Yeah, so nice to be here. So I think, should I just continue, Murali?
Yes, Prof. And of course, just before we kind of
Okay.
let you loose on the slides, we've got an important question to ask you because
Okay.
quite a lot of issues on this as well. So have you taken the vaccine and how was the experience?
Oh, you asking me personally?
Yes, Prof.
Yeah, I think I may have not mounted a very strong immune response because I practically didn't feel any problems at all. And I have to say, a lot of my colleagues, I'm a breast surgeon, so I think we continued our usual daily work like clinics, surgeries, and all that. So I do know some young people may have strong reactions like fever and all that, but so far so good. I think it's been quite a unremarkable experience for me
Oh,
personally.
good.
Yeah.
That's really good to know, Prof. And how about in terms of patients, Prof? Any of your patients yang nampak
Oh,
macam
patients.
had
I think,
problems with the vaccine
yeah,
and all that?
I think so far, like, I think most of my colleague, I mean, these first liners who are cancer patients who have received the vaccines have no problems at the moment, no complaints at all. But for I think we have not seen our non-frontliners yet getting the vaccines. But I'm happy to report even our older relatives who have received it are quite happy with it, no issues at all. My own mother will be going for her vaccination on Monday. So I'm
Right.
sure we are all happy to get our elders vaccinated as soon as possible.
Right. Absolutely, Prof.
Yeah.
Thank you so much. So you're going to speak to us, Prof, a little bit about vaccination and cancer screening, specifically on breast cancer. So please, Prof, I think as you were saying quite rightly, quite a lot of worries about this, quite a lot of queries pertaining to this as well. So how do we kind of address this, Prof?
Okay, thank you, Dr. Murali. So I'm just going to start with my slides. So okay, I'm not sure why my slides doesn't want to move. Okay, here you go. Yeah. So basically, we'll just talk a little bit about breast cancer screening, just touch very minimally on it, and what we have in terms of advice for people on the street as well as people who have breast cancer. Okay, so I think we all know there is a Malaysian guideline on the screening for breast cancer, for which we are only advocating mammographic screening for breast cancer. And this is performed every 2 years for women aged 50 to 74 years. And for women who have
Prof,
higher risk.
sorry, if I could just ask you for a bit. The screen is very small, Prof. Is there any way to make your screen bigger?
Oh, how do I make it
You have
big?
to okay. You have to change to PowerPoint. This is a
Oh,
with
I
speaker
know.
notes.
This is the speaker notes. Oh, you
Okay.
got this one and not the other one. Okay,
Yeah,
sorry.
we have to convert this.
You see anything? You see anything now?
It's
Not yet.
still on,
Not
I
yet.
think it's still on the speaker mode, Prof.
Oh, okay. Is it still on speaker now?
Yes.
Sekejap, eh? Is it speaker mode or is it on the other mode? Okay. Can you see it now? Is it on the usual mode?
No, not yet.
Yeah. Oh dear. Sekejap, ya. Okay, sorry about this.
No
Technical
problem, Prof.
glitch. Sekejap, ya.
And maybe in the meantime, while Prof sorts out the slides, maybe we can introduce Prof Kartini first as well. Prof, good afternoon. Pleasure
Hi.
seeing you.
Where is it? Am I on? Yes, I'm on. Okay.
Yes, but we can't see your video, Prof.
Okay. Hang on. Yes.
Okay, there you go.
Okay.
Pleasure having you with us. And
Thank you very much.
I wanted to ask you really a different angle of question, because quite a lot of photos circulating on Facebook on people who have had vaccines and how their lungs seem to be having quite a clear radiological image from COVID-19 as opposed to people who haven't had a vaccine. Is this true, Prof? I'm sure you've seen these videos as well, or
Oh my
photos as
God!
well.
It must be a prank, is it? I don't
Yeah,
think so. I've heard.
exactly. So just kind of debunking that, if you've ever heard about that. But
Well,
seriously,
I've heard a myth where they get the vaccine jabs and then they become stronger. Yes, physically.
yep. So that seems to be quite interesting as well. How was your vaccination experience, Prof? Did that go okay?
I think it was very uneventful, except for slight the local tenderness. But other than that, I know some of my friends had all this fever and chills and rigors, and some had myalgia and body weakness. Some of them do get that, but I think most of us just have a very uneventful side effects, and I think those are the normal, which we're going to talk about also. Basically, some of them have got this incidental lymph nodes findings on
Right.
imaging.
Right. Exactly, Prof.
Is Aishah
Will do.
okay?
Yes, I think Prof Aishah is good already.
Can you
Okay.
see my slides? Is it on presentation mode or what?
Yes, Prof. Now it's much bigger.
Is it,
But
is
it's
it
only
mode?
it's only half of it.
Okay, let me try and see if you can see it. Okay, can you see it?
Now it looks better, I think.
Is it presentation mode or the usual presentation? Because I've switched off my video. It could be my bandwidth.
Oh, okay.
Is it okay now? Chat, does it look like our usual slides?
No.
Still presentation slide. Oh,
Yeah.
Oh, this is not good. All right. How do I do that then?
It's okay already, Aishah.
Okay, now better. Yeah.
Okay.
Okay, dah. Okay.
Yeah.
All right.
Okay.
Sorry.
Okay. There you go, Prof.
Okay, so I was just going to tell you all for screening mammograms, we do it 2 yearly from 50 to 74 years, right? But for high-risk women, we can even go as early as 30 to 39, and also 40 to 49. And mammogram screening for 40 to 49 is usually for high risk is annually, okay? And for 60 onwards is biannually. All right, so we won't go into too much details about mammographic screening, but what we want to focus on is this immunization program where we are now in the fasa 2, where we will be doing more on the high risk groups. And we already know there are many types of vaccines, and I don't have to go into too much detail, but we know that the Pfizer and the Sinovac is actually available now for national screening. And for cancer patients, as you know, AstraZeneca was removed because they are so worried that there's a lot of side effects, which is really not, there's no evidence to say that it is more dangerous or have many side effects. Okay, so let's focus on 3 groups of people that may have issues with vaccination in relation to breast cancer screening, as well as having breast cancer itself. So of course, we have people who are non-cancer patients who may be attending mammographic screening. Okay, that's one group of people. The other group is people with symptoms and signs of breast cancer. And of course, the last group is breast cancer patients who may be on active treatments or they are long-term survivors. That means they are no longer on treatment, they are living as normal lives. Okay, right. So we do know that vaccine invokes an immune response, and as mentioned before, they may have fever and may have enlarged lymph nodes, and these natural responses would resolve within 6 to 12 weeks after the last dose of the vaccine. And this has been reported where you can find lymph node swelling in 1 to 2 out of 10 people given the Pfizer injection. Okay, this is from a very large observational study. Okay, hence the information about the date of the vaccination and the site of the vaccinations are very essential information to share with the doctors as well as the radiologists when they are performing all this imaging for patients. So I guess the first issue is enlarged lymph nodes. Okay, and for cancer patients, when we have enlarged axillary nodes, we always wonder, is this related to cancer recurrence? Or even for someone new who have other symptoms like a breast lump, for example. So is this a cancer that has gone to the lymph nodes? So even though we do not recommend any delays in vaccination or breast imaging in well women screening, women are advised to have their screening mammograms before being vaccinated or 6 weeks after the last dose. And all this information need to be documented on the patient radiology order. I think this is very much relevant to our GP colleagues, that it is noted in the order form itself about the vaccination status, the date of the vaccination, and the site of the vaccination. Okay, and of course the deltoid, it has to be mentioned, right or left deltoid that has been injected. All right. And for people who are being investigated for a breast problem or even having a breast cancer diagnosis that has just been made, or even people on active cancer treatments or follow-up, maybe vaccination is more preferably done in the thigh or buttock or the opposite arm or the deltoid. Okay, so all these injections can be given intramuscularly. And if you remember, our pediatric age group, usually we give it in the thigh, which is the vastus lateralis muscle. So that is a site that can be used so that we do not have any confusion if the patient develop any axillary lymph nodes. And so we encourage patients to actually go with appropriate clothing. They can wear skirts so that they can easily access the thigh area, the outer thigh area for the injection. So I thought I'll just share with you the pre-vaccination assessment that has been circulated by Ministry of Health. So these are the 3 groups of people who require complete pre-vaccination assessment prior to receiving vaccination jabs. Number 1, people with weakened immune systems or medical conditions or treatments. So you can see cancer patients is actually in that group of patients, okay? The second group is the individuals with severe allergic reaction or anaphylaxis. And the last one, individuals with bleeding disorders, especially those who have hemophilia, People, and don't forget, just to mention, yeah, a lot of people are on Plavix and aspirin. So long as the patient is only on one treatment, blood thinning treatment, they can go and have their vaccination even with no problems, okay? But I thought I'll put this up so that GPs can actually assist us, doctors and specialists in the hospital, because we cannot help, write out all these letters for all our patients, especially the patients who are long-term cancer survivors, who are well enough to receive the vaccination. Okay, so how to get access? So they say consult your regular doctor or medical specialist. So I hope the GPs can play a major role here to assess some of our cancer patients that don't need to see the oncologist for this purpose. Okay, so for issues, there is no follow-up treatment such as severe allergies or no regular doctor visit, you may go to a nearby clinic kesihatan. Okay, so that's the other option, but we know our KKs are extremely inundated with patients now because of the COVID surge. So it's good if our GPs could step in to address these issues for our cancer patients. And this letter can be issued by the specialist who examines you. But I think GPs who are now hopefully knowledgeable after this short lecture about which treatments we can proceed with vaccination to help us in this quest to make sure all our patients have had a doctor's assessment. So what is the outcome of the assessment? We want to know the eligibility of the vaccination, whether the vaccination need to be postponed to a more suitable date, or that if they are not eligible due to the contraindication. So the contraindication, I think, for most cancer patients is actually allergic reactions, as well as if they have bleeding disorders. Having cancer on its own does not contraindicate someone to receiving vaccines. Okay, so this is how the letter looks like. So we have been, some people have been circulating this. This is from Ministry of Health. You can actually help to fill up this form so that the women or the patients who go for their vaccination do not get rejected on site because they're not sure about the therapies and so on. So which cancer patients are suitable for the vaccination? Right. So, okay, as mentioned, all patients should go for their vaccination unless they have severe allergic reaction like anaphylaxis, okay? All right. But there are some treatments that affect the immune system, and hence it will affect the effectiveness of the vaccine. It's nothing to do with any contraindication to that patient receiving the vaccine. It's just that these medications may actually make the vaccine worthless, useless. Not worthless, useless, because the immune response cannot mount a response because of their current treatments. So what are these treatments? Okay, number one, chemotherapy. But chemotherapy, you know that the immune system usually normalizes after 3 to 4 weeks after the last dose of the chemo. So the chemo, ideally, if anyone is about to start their chemo, get your vaccination first if it's not going to delay your chemo, okay? But if you are on chemo, you can talk to your oncologist and see how you can strategize the timing of the vaccination, okay? Or you may want to completely delay until you complete all 6 cycles, and then only after about a month after the last chemo, get the vaccination, okay? The second group of medication is called the immune therapy medication or the immune checkpoint inhibitors. The names of this medication is pembrolizumab, atezolizumab. This type of medications will affect the immune system of the patient. So this is best discussed with the specialist oncologist. Okay. The last group of drugs that may affect the immune system is drugs called CDK4/6 inhibitors, and they are all the cyclip. The names are usually ends with cyclip, palbociclib, ribociclib, abemaciclib. Okay, these drugs may affect their neutrophil count, so they may have low white cell count. So this again need to be discussed with your oncologist. Okay, all right. So let's go to other treatments that does not affect the immune system at all. So I think GPs, if you see your patients on, let's say, just on tamoxifen and they have been on it for years and they are well, they have no anaphylaxis history, these patients can get vaccinated, okay? Aromatase inhibitors, letrozole, anastrozole, exemestane, or even this drug called Faslodex, which is an immune drug, hormonal therapy, which is given intramuscularly. These drugs are all, they can proceed with their vaccination. Okay, targeted therapies like Herceptin or now we have a lot of biosimilars or the generic name is trastuzumab or pertuzumab. These drugs, they're all able to go for vaccination, but it does not affect their immune system. And some patients may actually be on bone adjuvants, like zoledronic acid or denosumab. So these drugs are not going to affect the immune system, hence patients should go for the vaccination. So again, we already mentioned these are the 3 groups of patients. So, okay, before I will conclude, okay, let's look at this table. When we are looking at all patients who are non-cancer patients, just you need to know is about the timing of the vaccination and the mammogram. So ideally, the vaccination should be done before any screening mammograms, or at least after 6 weeks after the vaccination. And if there's no urgency, you can even wait after 3 months, you know, or 12 weeks after the vaccination, so that you don't get any false positives on the mammogram. Okay, the second group is people with symptoms and signs of breast cancer. Okay, this type of people who may have a breast lump, may have palpable lymph nodes, you should refer on to breast or general surgeons for a diagnosis as soon as possible. So do not delay the referral. As for the vaccination, we should explain to the patient that they need to get this diagnosis done quickly, maybe within the next 2 weeks to 3 weeks, so that they can be, once they have been cleared or they have been diagnosed, then they can go on to do their vaccination. Okay, all right. The next group is all the breast cancer patients that I mentioned before, those on active immunosuppressive therapy. This is the group of patients that need to discuss with their oncologist because they need to time the vaccines to the right time. Okay. The second group is when they have active treatments, but they are not going to affect their immune system. This one, just go ahead and vaccinate. Okay. And for long-term survivors who have not on any medication and they are well, no anaphylaxis and so on and so forth, they can just go ahead and get their vaccination. So I hope with that conclusion from my side, I think just get vaccinated. Okay. Number 2, don't delay diagnosis of cancer. Even if we have a lockdown, the hospitals are open for diagnosis. Okay. And of course, those on immunosuppressive therapies, the timing is of very important. So this one, you need to get the oncologist to see them. Those on non-immunosuppressive therapy, please certify them fit for the vaccination. And if the patient, the well patient, needs mammogram screening, or even the cancer patients who is a long-term survivor needs a screening mammogram, do it before the vaccination or 6 to 12 weeks after the vaccination. Okay, so that was actually my last slide. And I think what we wanted to do was for Prof. Kat to tell us what will happen if you find somebody with lymph nodes after the injection. Okay. So with that, I will pass on to Kat. Maybe then later we can take questions. Murali, what do you think?
Yes, Prof, let's do that.
Okay, I'll stop sharing.
So we'd like to get Prof. Kartini now, who has also kindly kind of dropped a few PDF documents on your chat box here.
I was mute. Okay, sorry.
Okay.
Hi, good afternoon, everyone. Thanks, Murali, for the kind introductions. Anyway, I've dropped some articles in the chat box. These are some of the recent imaging guidance and discovery of all these incidentalomas on imaging, not just for breast, but also for a lot of cancer staging. Okay, I would like to share my screen now. Hang on. Wait. Okay, hang on. Okay, share sound. Hang on, share sound, share. Okay, am I on?
Yes, you are, Prof.
All right. Okay. Hi, good day. This is going to be a very short and interactive and simple, free and easy. Okay. So it's actually, the title was some cancer screening, but most of us do a lot of, when it comes to cancer screening, you only know of a few disciplines and modalities, which are breast cancer, sometimes the prostate cancer, and not much of the other cancer. So when you talk about screening, we talk about breast cancer most importantly, because you do the mammogram and the MRI. Okay, so breast cancer screening, we know that. So most of us do the mammogram and sometimes the MRI. Early detection is very important, but we know the first imaging modality is mammogram, and then comes the rest, where sometimes some places they do ultrasound as well, and you may get findings in the breast as well as the axilla. So why we do the cancer screening? These are healthy, normal controls. They do find masses or suspicious findings on mammogram and other MRI. So why? Because you want to catch them at early stage and improves detection, and then improves survival rate, and then better treatment and outcome for these patients. So for breast cancer, it's typically mammography and breast MRI. And then you come to the breast cancer diagnosis, where you will do all the conventional imaging such as CT, as well as the PET scans. So when we look at this mammography, we do the two views. This is just for radiologists, but sometimes I think general practitioners also, they do refer to us for mammogram screening. Sometimes there has a person that has history or any symptoms, but they do refer direct to the clinic, or sometimes the breast surgery clinics. So the aim is to detect cancer, all right, to reduce morbidity and mortality from the disease. This is the mammogram, where you see cancer, but you also see lymph nodes in the axilla. Just as I'm sure all of you are doctors, you have seen mammogram. We are looking for cancers in the breast. Sometimes it's calcification, sometimes it's stellate masses like this, but you also see lymph nodes in the axilla, usually on one view. This is the MLO views, where you see lymph nodes. So this on the left side, where you see here, we have fat containing reniform shape lesions. These are lymph nodes with preserved fatty hilum. On this side, you see here, this is a cancer, but you see the cortex is slightly thickened. So these are indeterminate or suspicious lymph nodes. So imagine if this patient comes in with this mass in the mammogram, but in this pandemic era, you have to find out whether the patient had received vaccination, or maybe had received any other vaccination apart from COVID, because they can get incidental axillary lymphadenopathy from any other injections, especially when it's injected at the arm area or the deltoid. Okay, so this is the guideline. You see average risk. We start mammographic screening. This is the average age from 50, and we stop at 75 years old. I think international guidelines says now you stop at 5 years before the expected expiration date, right? So if you're expected in, let's say in our country for females, it's maybe 75, so you stop at 70, or when it's 80, you stop at 75, right? Moderate risk, and then it's earlier. They are usually started earlier at 30 or 40 years old using mammography and sometimes MRI. So this comes the problem when you get vaccination. So vaccination, post-vaccine adenopathy is not common, but it has been found to be demonstrated or present in those that receive certain vaccines. Those are typically the mRNA vaccines. So I think Prof. Aishah had shown the table earlier, where you see there are many types of vaccine. You have the synthetic, well, it's not synthetic, but it's not the live attenuated vaccines. You get the mRNA, which are the Moderna and the Pfizer Biotech. We do not get Moderna, but we get the Pfizer Biotech. And luckily, the incidence of axillary lymphadenopathy is quite low in Pfizer, 0.5 to 3%. 3% sometimes they say after the second dose. I've actually encountered some of my friends who got axillary lymphadenitis, but of course we don't do the ultrasound because we don't want to cause unnecessary concern. So they do get lymphadenitis sometimes, or axillary swelling. But in contrast, this Moderna vaccine, you can get up to 16% of people. So there is a very well-known side effect, or it's called just a normal reaction, right? Due to all the reactions that we've explained earlier, why you get the immune reaction, the better the immune reaction, the more aggressive it is. So these are usually seen in Moderna and maybe less in Pfizer. I've not encountered, or I think most of the articles, even the literature says that AstraZeneca and the Sinovac and Sinopharm do not usually have this axillary lymphadenopathy or supraclavicular lymphadenopathy as their side effect. But if they do, they might be underestimated because, you know, we do not get all these publications out of the other vaccinations, right? So this swelling typically subsides within a few weeks. Actually, it's few days, 3 to 4 days, and it should be totally gone within, let's say, 2 weeks, right? And it occurs on the same side. So if you get vaccinated on the left side, you should get the nodal adenopathy on the left side, not the right side, okay, or the supraclavicular. And you know that it's usually coincidental with the injection, okay? So like Prof. Aishah just now say, if you know the patient has got cancer, because there are a diverse group of people who's going to receive now in the second rollout. These are all the vulnerable survivors, the patients with a lot of not just breast cancer, but other cancers, lymphoma, lung cancer. And these are the cancers that, you know, if you get any palpable lymphadenopathy from the above the neck or area of the axilla, you'll be concerned that they might get recurrence. So these are the things to look for, not just breast cancer, but also for other cancer surveillance. Okay, so the post-vaccine adenopathy and imaging, right? Incidental ALN is axillary lymphadenopathy. SCF is supraclavicular fossa adenopathy. It may be concerning and mistaken as a sign of cancer on routine imaging such as mammograms, MRI, CT, or PET scans, especially when you don't know. So up till now, nobody, I can bet nobody in the radiology department or anybody in the clinics will ask you when is your last vaccination. Why? Because before this is just the first, the frontliners. So next we're going to have the community getting the vaccination. So it's important and imperative now to document when they get the vaccines, especially now that you have several vaccines on the rollout. Okay. So what is the implication to screening, specifically screening mammogram and ultrasound? So Radiology and Breast Imaging Societies have recommended that we postpone routine mammogram. I think it's difficult to do that in PPM because our waiting list is a year, and if we tell them we want to postpone, they go freak out and then start complaining here and there. So the best is actually either you make sure that it's documented and then or let them know, because usually in My Sejahtera, they will let you know in advance. Like now, you sign up for the My Sejahtera for the AstraZeneca, you will get it a month later. So they would know when their mammography examination is. So either they can't postpone the vaccine date, definitely not. I don't think the government will tolerate that. So what they can do is they just inform the radiology that, you know, within a month, just try to reschedule up to 6 weeks after the final vaccine dose. The problem is like Pfizer, you have a 4 weeks gap. So it can be done within a month. But for AstraZeneca, I have been informed that it's 12 weeks. So you may get in let's say in May, and then you want to postpone it for 4 months. If the patient is going to get the vaccination a month later and they inform you, I think it's only right that you tell them to come earlier before the first dose. That will be better, because this screening is too yearly. If you give them another 5 or 6 months date, they either totally abscond or you may not have another chance of doing the mammography, right? Scheduling screening exams for the receiving of the first dose, okay? So this is an example. This is a mammogram. It's very nice and fatty. There's no masses. But this is from a journal publication where they typically encounter post-COVID adenopathy because they roll out the Moderna and the the Pfizer cases. So you see here, we don't have Moderna. So far, we've not gotten any patients with incidental adenopathy. So you see here on the left side where there are multiple nodes, but there's one with loss of fatty hilum. So that is suspicious. Hello? Hello? Sorry, there's a Murali?
Yes, Prof. I'm looking to see who is it.
Okay, all right, sorry.
I mute dia, okay.
So on the left side, you see there's a lymph node here with loss of fatty hilum. So that's suspicious, but you don't see any masses here. And on the right side, this is a previous mammogram where you see similar nodes, but this node was not as enlarged and there's no loss of fatty hilum. I mean, it's difficult to see fatty hilum here. Probably this is a thickened cortex, but in countries where they only do mammography, they do not call back the patient for ultrasound. So this was only, they don't recall the patients. They just tell them that this is likely going to be post-COVID adenopathy. And if they do get persistent symptoms, they have to come back for a follow-up or review. Okay. This is another one, okay, a 33-year-old with probably a high-risk screening, maybe BRCA or maybe very a genetic high risk in the family. So you see here, they do yearly MRI and a yearly mammogram. So this is a normal MRI. There's no masses, but you see here multiple nodes in the left side. And most of them looks very suspicious because there's loss of fatty hilum. But because they know that the patient had the second dose of Moderna, they decided to they decided to just give it as a BIRATS-3. That means it's a benign finding and requires follow-up. So it can be either imaging or you can do a clinical follow-up. Why is it important in MRI as opposed to mammo? Mammo, you don't usually see the level 2 or level 3 nodes. It's usually the level 1, very superficial. So MRIs and CTs are the one that will usually demonstrate all these level 1, level 2, level 3 nodes. And it might be concerning because if the patient has got lymphadenopathy, you want to make sure that the patient has got no occult breast cancer. Okay. This is an ultrasound. This is a common imaging modality where you see here, this is a patient who had a unilateral left axillary adenopathy 5 days after receiving the second dose of the Pfizer. So I said earlier, only 0.5 to 3% of Pfizer recipients can get this adenopathy. That even then, if they are they do feel the symptoms, but sometimes it's just incidental. So they may come for ultrasound and mammogram. So those places who do ultrasound for dense mammogram, you might encounter this. So that's why we have to demonstrate or document when the vaccination, first dose, second dose. And I think it's very important also to document what type of vaccination. And usually that is available in India, MySejahtera card. Okay, so you see here, there's a lymph node, but there's thickened cortex. Okay, very vascular. This is typical finding of even normal nodes, but you see the rest of the nodes is not so thickened. So there's only one and multiple here. So post-vaccine adenopathy and imaging, what is the implication in both patients? Because they know that the patient had previously vaccinated, and it's a screening imaging. That means it's just a mammogram, not a diagnostic. So it's isolated finding with no abnormality in the bilateral breast. So given recent COVID-19 vaccination, the cases were interpreted as BIRATS category 2 and just discharged and to come back in another year or 2 years time. So the report impression stated. So this is one of the things that I think we can try to learn or emulate, make sure that you have to put the disclaimer, enlarged lymph nodes in the left axilla are benign in the specific setting, and in the clinical context, document when is the previous vaccination or last vaccination, make sure it's ipsilateral arm, axillary adenopathy is a benign imaging finding. So no further imaging is indicated. This is important because a lot of people ask me, if you get ultrasound and you see thickened cortex, are you supposed to do a 6-month ultrasound? That is going to strain our resources because you know the COVID adenopathy will only last maximum a month or so. All right, if there's clinical concern that persists more than 6 weeks after the patient's final vaccine dose, then the axillary ultrasound is recommended. So this is a snapshot. This is a visual abstract of unilateral lymphadenopathy after COVID-19 vaccination, a practical management plan for radiologists across specialties. I think I have appended the article in your chat box. So you see here, when you encounter a UAL or unilateral axillary lymphadenopathy seen on different imaging modalities, because this paper talks about mammogram, they talk about CT, they talk about PET, they talk about MRI, they talk about everything, any cancer patient's diagnosis and screening, because sometimes you don't know what the patient has, all right? As long as you find something and it's a cancer staging modality, So these are the recommendations. You make sure you document the date, injection type of vaccine, right? You know, Moderna and Pfizer has side effect of lymphadenopathy, albeit very low. Okay, for patients with no other health concern, they can be discharged, but in the clinical setting, to stage a recent cancer diagnosis, example, head and neck cancer, or lung cancer, or maybe a lymphoma. So this will be concerned because you're going to find lymph nodes in the axilla and you're going to find lymph node in the neck. So what are you going to do? Are you going to just let go? Oh, say that's vaccine side effect. How are you going to convince these patients, right? So you have to make sure that you refer them to the direct discipline. Okay, let's say if they are lymphoma, go to the oncologist. If they are breast cancer, please go refer to the breast surgeon. If they are head and neck, please refer to the head and neck oncologist. All right. Prompt vaccination, possibly at site most distant for known cancer, is one suggestion. That means if you have a breast cancer on the right side and you have all the chemo pot and everything, make sure they do it on the contralateral side, or sometimes you can do it at the thigh side, if I'm not mistaken, right? So recommendations aim to reduce. Why is it important? Because when you tell them, I want to follow up, why? Because it might be cancer. You are going to cause unnecessary anxiety and concern. You're going to burden the system. You're going to burden the clinic. You're going to burden the imaging imaging department. Okay, cost of unnecessary evaluation. So let's say you follow up in 2 months, some people like to do 3 months and it's still there, you're going to have to biopsy, right? But if it's cancer, make sure that you do the appropriate imaging modality. Further delays in vaccination, and recommend imaging for best patient care. But the keyword here is do not forego your vaccination. It's very important, okay? This is a nice algorithm, chart flow. Algorithm for axillary lymphadenopathy in the setting of recent, within 6 weeks, bilateral deltoid muscle COVID-19 vaccination across specialties, not just breast cancer. So if you have a ipsilateral deltoid muscle COVID vaccination, if no other additional imaging findings, let's say the mammo, the CT, the MRI, or the PET scan, shows no other disease, no cancer, no recurrence, just the axillary lymphadenopathy on the site of injection, this is a benign clinical finding. No imaging is indicated at this time. If there is clinical concern that persists 6 weeks, the keyword is clinical concern, right? After the final vaccination dose, axillary ultrasound is recommended. So this is true for any type of cancer, if I'm not mistaken, because next you're going to do a biopsy, right, which is under ultrasound guidance and not the primary imaging modality guided. If there are additional imaging findings not related to lymphadenopathy, example incidental cyst or renal cyst or hepatic cyst or hemangioma, these are benign lesions, also benign. But if it's possibly related, that can be assessed during multidisciplinary team discussion. Okay, oncology has all these tumor board meetings every week, so they decide whether the findings are concerning or not. So this information on the vaccine needs to be disclosed to the relevant teams. Okay, possibly related to lymphadenopathy, ipsilateral suspicious breast or lung findings. Management at discretion of radiologist or referring provider. So look at this, at discretion on suspicion and location of associated lesion, appearance of lymphadenopathy, and or pathology results. So this already reflects that you need a multidisciplinary team discussion and consensus opinion. If there are current cancer patients, pre or peri-treatment, that means during the cycle, let's say hormonal therapy or what, I think Prof. Aishah has already comprehensively described how to approach patients with immunotherapy and not with immunotherapy. The contraindication is usually allergy or very bad allergy to vaccine. Other than that, there's no other contraindications that I can think of. So those, unilateral lymphadenopathy, biopsy versus imaging, clinical follow-up at discretion of oncology treatment in consultation with radiologists. Okay, this is also in the PDF file that I've given you. This comes from the other abstract, visual abstract recently. So the thing is, we the breast surgeons and radiology, we are trying to decide what is the best guidance imaging that would be practical for our setting, because it's difficult to follow that algorithm where you have a lot of multidisciplinary participation. So if we have this as an example, I mean, this is adaptable. We haven't finally decided on the last version, but if you, same thing, if you get a recent vaccination at the arm and you get lymphadenopathy, if no additional clinical findings, this is a benign finding. Any other suspicious clinical finding or imaging, you have to review for breast, lung, lymphoma, and other suspicious symptoms and sign. If you have recent cancer patients, you have to recommend for the imaging. That means if you do a, let's say you do a CT and you find that there is a adenopathy, then you have to discuss with the respective oncologists and recommend for the imaging, ultrasound, mammogram. And these are not the patients that you would want to see in 6 months or 3 months, because you may not be able to tell whether they are adenopathy COVID vaccine related or recurrence. Okay. All right, this is for the breast radiologist or the breast surgeon. The Society of Breast Imaging have this screening mammogram and Q&A, what to do. These are for the layman, not the health care providers, but more for the patients as well as the public, right? How to do, when to do, right? And we should come up with our own in the future. Okay, this is a multidisciplinary recommendations regarding post-vaccine adenopathy and radiologic imaging. This is similar to the previous one I showed, but this is a very comprehensive table where what to do, when to do, and how to follow up these patients when they have COVID adenopathy. All right, okay, you can check. If you do not find it in your chat box, you can email me and find the relevant articles in the PDF file. Thank you so much. I think that's all that I can share. Okay, I have to. Hello?
Okay, we got it. Thank you so much, Prof.
Have I unshared? Have I unshared?
Yes, you
Okay.
have, Prof.
Okay.
Okay, thank you so much, Prof. Kartini and Prof. Aishah, for I think very comprehensive kind of insights from Prof. Aishah and Prof. Kartini, both on this issue pertaining to vaccination and cancer screening. Ladies and gentlemen, as you all know, feel free to kind of drop the questions into the chat box, and so that we can feel free to put up some questions to Prof, either one of the Profs. And Prof, there's some questions coming from the FB as well, so I'm just going to take them for you, yeah? And then maybe just to both of y'all and see who wants to kind of field the question specifically. If it comes to a specific expert, I will then let it go to you specifically. Prof, so there's one question from someone who says, if my patient has been vaccinated and is now has come to see me after about 5 to 6 weeks, they may have a lymph node. So do I tell them to wait before going and doing ultrasound or mammography, or should I just tell them to go immediately? And I think this is within that window period, about 5 or 6 weeks. Is there like a time that we should wait a little bit as well?
Okay,
Maybe
sorry.
Prof. Aishah?
I think they want to know whether imaging is supposed to be done. Aishah, you want to take this?
Yeah, okay. I think so. I think if you look at what Prof. Kartini shared just now, because we had some discussions about this, because if we are going to image everybody, it's going to be a big resource issue.
Constraint, yeah, resource constraint.
Everyone. So, if you feel there are no other symptoms or signs to suggest that this is something.
Aishah.
Sorry, we lost you, Prof.
Yeah.
Vaccination within the last 6 weeks, I think. Really, yeah? Oh my gosh. Okay, let me stop my video because maybe it's the battery. Okay,
Yeah.
can you hear me now? Is it better?
Yes, Prof.
Yes.
Yes, much better.
All right. So the if there is a clear history of vaccination within the last 6 weeks, I think you can observe the patient, because you do not want to over investigate patients. And we do know that having lymph nodes after vaccination, especially where on the same side of the injection, so it's a unilateral axillary lymphadenopathy, because most of them will receive their injections in the deltoid muscle. So if there's a clear history of that, I suggest we observe. But if let's say on your clinical examination, you find another breast lump,
Yeah.
then in that situation, refer on to either breast surgeons or general surgeons so that they can quickly start off the triple assessment, the imaging and the biopsy and so forth. So if the patient has just an isolated palpable axillary lymph node, which is tender, just observe, wait and see. Okay. Give yourself maybe up to about 6 weeks or 8 weeks after the vaccination. But beyond that, then of course that discussion about having further imaging, I think the first step would be an ultrasound of the insula. And if the patient is a woman, then you may consider doing mammogram.
Oh yeah, but we forgot to ask.
Of,
The patient was male or female?
They
Yeah, we
didn't quite
forgot to ask that.
specify. Yeah, I'm assuming female, Prof. Yeah.
Okay, I mean, of course, men can get breast cancer. Okay, 1% of our cancer patients are males. But if there's any doubt, I think just refer on, but you don't need to refer everybody. So if the history is very clear, there is that history of vaccination, is on the same side, there is history of tenderness, fever, then I think it is most likely a reactive lymphadenopathy from the vaccination.
I think the next, Aishah, the next question would be, do you treat lymphadenitis post-COVID? Do you give symptomatic or?
You can give anti-inflammatories, I think. You can give maybe COX-2 inhibitors or NSAIDs or paracetamol, for comfort and reducing the inflammation. But otherwise, there's no treatments like even antibiotics and all this. I think we should not overuse antibiotics. If there's a clear history of the vaccination, we take it at face value, and there's no other symptoms of suggesting cancer, and you have examined the patient for any palpable masses in the breast or any in the neck, for any other lymphadenopathy elsewhere. So if that's the case, just leave it alone, monitor and reassess the patient in about 2 weeks or something like that to make sure it disappears. Okay, so monitor until resolution. I think that's the word we use. Just keep on asking the patient to come back for a clinical assessment. And then if the patient really, everything becomes okay, then fine, don't need to do anything. But if it is persistent, then refer on for triple assessment.
Okay, will do, Prof.
Okay.
Prof, there's quite an interesting question as well. And this one is, how about if there's a patient who has had COVID, not the vaccination, but the disease itself? So how long do you think they should be given a gap to restart, like screening? Should we tell them to wait a certain number of months or something like that before they come back for cancer screening?
Okay, my question would be, how safe, I mean, right now when, I think those days last year when patients had COVID, I think they're not allowed to, they're still a quarantine, correct? Up to 2 weeks, if I'm not mistaken. Yeah. But now they found that after day 10 or day 15, you're no longer infective, even though your CT COVID count is elevated or positive. So I think more the question is more of the screening, whether they're going to be infective to other people, or whether you're going to encounter lymphadenopathy from COVID infections itself. Yeah, and COVID infections do not routinely cause axillary lymphadenopathy. We've seen countless of CT thorax and well, we cannot see axillary lymphadenopathy on the X-ray, but CT thorax. And I've yet to see any axillary or supraclavicular lymphadenopathy. Even mediastinal lymphadenopathy is quite uncommon. So I think the question is whether it's for screening purposes, whether it's going to be a difficult diagnostic conundrum for the physicians. Is that what the question is?
Yes, Prof. So I think it's like, I mean, it's very general. So it might indicate that what you're saying, whether there is lymphadenopathy, and because of that, should we wait?
No.
And so that's a no.
As long as they are safe, and of course, if they suddenly comes up with, because we do have some symptomatic patients, and suddenly they become COVID, in the ward.
Yep.
So that you have to image them, no matter what. But at least we know that they are COVID positive, so we will institute appropriate measures right? Because we do get sometimes patient breast cancer diagnosed and then suddenly we want to schedule for operation and they are COVID positive. So the operation can be postponed, but the imaging can be performed if it's indicated. That means if they do want to have an urgent mastectomy or urgent treatment, I don't see why patients should have urgent mastectomy, but sometimes they do want the imaging done urgently. So it just needs to be informed to the appropriate or the relevant people before the imaging is performed. But we don't normally do. If it's for screening, they should be well maybe a month after the diagnosis, and they are well to be mobilizing in society.
Right, right. So I think Prof, the time period you're saying is more or less about a month, then you're
Yes,
much more
yes.
comfortable getting them back into like screening and all that. Of course, this as Prof was saying doesn't apply if you're having symptoms lah. If you're having signs and symptoms, then
okay, yes.
then becomes a need
Different.
to image more urgently lah. Betul.
Correct.
Okay,
Yes.
got it, Prof.
Okay.
Got it. Prof, another, I think, quite an interesting question. I think this one maybe Prof Aishah also take.
Can I ask? Somebody asked before 3 o'clock about the virus mutation and then it gets weaker.
Yes, Prof. Okay.
We are not the
right.
correct people, but why are variants more virulent?
Oh, okay. I was going to address this possibly.
Yes, please.
Yeah, this is. I was just going to leave it until the end so to get both of y'all on the relevant areas first.
Okay.
So
right.
there was a question on this as Prof has brought it up on mutations, and we understand that as the virus mutates, it gets weaker. But why are variants more virulent? Actually, just to clarify, the virus can mutate. Any virus actually continues to mutate, and different viruses like the coronavirus, we know it mutates far more quickly than other more stable viruses. Now, when those mutations do occur, they can occur either way. They can occur in a way that the virus gets more virulent, or it can actually mutate in a way that the virus gets less virulent. So these mutations are actually quite random. Now, what happens with less virulent mutations is then the transmissibility of the virus itself reduces, and over time these mutants die out because they can no longer be passed from one infected person to the other. And what happens is, in those variants which are highly more virulent, these are then the versions or the types of virus or the variants that actually get transmitted because of the fact that these mutations have now made them much more infective. And very interestingly, just to add to what Prof Aishah was saying in the message, because Prof Aishah mentioned this point as well. And what happens is, as you start vaccinating people, we are discovering that the virus actually mutates aggressively due to this kind of biological pressure. It tries to overcome the effect of the vaccine onto its its own kind of survival. And when these mutations do occur, and we call this like immune escape, the virus is able to mutate beyond its ability and can then cross. If you vaccinate many people, the virus cannot then, even though it's mutated, this variant which is now aggressive, it cannot actually cross on to the next person. And that's exactly coming back to why vaccination now becoming more and more important, because that actually helps to reduce the emergence of new variants as well as the propagation of these new variants in the community. Sorry, lengthy answer. Hope it managed
Wow,
to...
Murali, impressive.
Okay. Hopefully, Prof. Prof, there's one question to I think Prof Aishah.
Okay.
And this was actually quite interesting. It has come up in a previous session as well. I think very similar thinking individuals. So if I haven't got the vaccine, and then now I'm thinking that I should be planned to get a biopsy or something like that, or it says inpatient surgery. So do I delay the surgery until I get vaccinated? Is there going to be a difference? Is there a higher chance of me picking up COVID as an inpatient? So some thoughts on that. Maybe Prof Aishah would be the better person to give comments.
I think there's a big fallacy, that you can get infected in a hospital much more frequent than if you go to Pasar Malam, So I think we have to recognize that a lot of the hospitals have SOPs that actually separates the people with COVID-19. In fact, all the pathways, like how to move a patient from one department to the other if they are COVID positive, is all being managed very, very well, So I think we should be, for people who actually have symptoms and planning for surgeries for cancers, things that cannot wait, I think you should not be very, very scared of going to hospitals to get these therapies, because the hospital, even though they are COVID hospitals, or now we don't even have COVID hospital, every hospital has COVID patients, they are all actually managed to ensure that there is no cross infection within the hospital itself. That is why I think you have to recognize all patients coming in for elective surgery need to have the COVID testing done. And now we even have SOP for home isolation before admission to cut down the numbers of people in the hospital. So, but when you have done your COVID test and you're planning for elective admission, you need to be isolated at home. So you cannot have contact with other people. You have to be in your own room for the few days that you wait before you get admitted for surgery. So whether or not having vaccination before surgeries would be important, and I have to say this for the breast cancer patients, most of the operations that we do is actually quite, I mean, even though we call all surgeries major, but it's one of those surgeries that is less, less hours spent in surgery. So I think maximum number of hours for cancer surgery is probably, for breast cancer anyway, probably the latest would be 2 hours. The least maybe about 1 hour or so. Okay, so it's not a long operation. And if you have had your COVID test done, you are not, you're COVID negative, you are healthy, you've been passed by the anesthetist to be healthy and able to manage and withstand the operation, there should be no reason for you not to have surgeries before the vaccination. Okay. If you are going for elective surgery, let's say the surgery is not so important, maybe it's for cosmetic reasons, or maybe it's a repair of a hernia, something that can wait, of course it's better to get vaccinated, So I think if you have a condition that requires urgent surgery just because maybe you have cardiac problems, you need a bypass surgery for your heart, or you have cancer and you need breast cancer surgery, don't delay these surgeries. The vaccination can be done later. Okay, but yeah, so I don't think there's any issue lah, Murali, in terms of recommendation in terms of the surgery and the vaccination.
Lovely. Thanks, Prof. Prof. Kartini, I had one more question, Prof. And this was really because you spoke about it, and I think someone has kind of picked up on it, especially with this rollout of the AstraZeneca vaccine, which really seems to be on a lottery based. Let's say you do get picked.
Roulette, not lottery.
Yeah,
Roulette.
So roulette. So on like roulette, and you suddenly get picked for an AstraZeneca vaccine, but you've already got a scheduled appointment to go and get some kind of cancer screening done, assumably, I think mammography or ultrasound. Should they, in between the first dose and second dose, there's a 3-month waiting period. After the first dose, can we, after that 6 weeks, without waiting for the second dose, go for screening?
Remember my algorithm and my chart just now? Should I? Okay, I think I shared the algorithm. There's a screenshot in there.
Yes, you did.
Either you do the mammogram before the first dose, or you do after 6 weeks after completion of the second dose.
Second dose, yeah.
I know AstraZeneca has no, not reported many axillary lymphadenopathy, but we don't know. We don't know. I think this must be the second version of the AstraZeneca that we're getting. The one, the clinical trials they did was the first version. This one will cover the UK variant, the African variant. So we don't know much about this. The thing is, we're trying to mitigate the complications and we're trying to avoid all these uncertainties. So if you get the date for vaccine AstraZeneca,
can I add on to that? Haven't they removed AstraZeneca from the national vaccination?
No, darling. It is not. It is in the vaccine rollout, but it's not in the national. So can Yeah, but
So
50,000.
I think just to remind everybody that right now the current vaccines that have been earmarked, right, for national program right now is the Pfizer, the Sinovac, and then the Russian Sputnik, right, Murali?
Sputnik and
Sputnik, Sinopharm.
CanSino Biologic. Yes.
Right. So far the ones that have been registered with our national pharmaceutical regulatory agency is just the Pfizer, Sinovac and AstraZeneca. And AstraZeneca has been removed, and very smart people have had their vaccinations done very quickly over the last few days. I know there's so many people on social media showing their vaccination status. But I think a lot of people are so scared, of all the side effects. When you have to be happy that we all live in Malaysia, we have a very strong national pharmaceutical regulatory agency that actually ensures the safety, of this drugs before it's being registered in Malaysia. So I think don't listen, I think they've got too many things going on WhatsApp, on Facebook, on whatever. And there is a lot of news. Even I met some patients yesterday telling me, Prof, betul ada orang mati dekat PPUM, ada staff mati sebab vaksin dekat PPUM. I said, we don't have anyone who had this type of problem, So all these things that goes around social media is going to be damaging, for your confidence levels.
Yep.
So
But
please
Aishah,
to the right
no. So are you saying that these people should not get AstraZeneca?
No, I'm not saying that. I'm saying that they don't have to worry anymore because some of them are so AstraZeneca. But AstraZeneca is like this. If you go to a vaccination center today or the next few weeks, you
Hello, we lost you.
given
We lost Prof. Aishah again. Okay.
this logistics of managing lost it. Sorry lah. The vaccines need good logistics, right?
Okay.
Can you hear me?
Yeah.
Yes, we can now, Prof.
So I think don't just go, the choice of vaccines, I think is all safe, The only reason why you shouldn't get vaccinated if you have had severe allergic reactions, the anaphylaxis, or you have hemophilia, stuff like that makes you get blood, your blood doesn't clot very well. So in that situation, of course, there are ways of even going around that. Even people with hemophilia, you can give the factor 8 and all that before the injection.
Is it?
Yeah,
That's
so
great.
there are many recommendations, and I really I put the second edition of the Malaysian National Cancer Program the guidelines. Please have the recommendation. Please look at it. And there's also one by the hematologist that clearly say even if you're on aspirin, you're on Plavix, and you're only on a single antiplatelet, you can even go ahead and get the injection even without stopping the dose and all that. Okay, so please read this document. I'll try and put up the hematological recommendations there so that you all can have a look. Okay, I'll put that up for you all.
I think you guys have to load all the PDFs before the Zoom disappears, because once the Zoom disappears, some of the thing.
Okay. There's Prof, there's one more question, and then I think
Mine,
this is, I think, quite general,
okay.
but I think might be something very relevant for us to answer. I think this gentleman asks, why are GPs with limited facilities to cater for emergency resuscitation given the task to vaccinate high-risk groups in phase 2 of the national vaccination COVID-19 program when it should be undertaken by hospitals? So doctor, just to kind of clarify, that's exactly why we're talking now about the pre-vaccination assessment. And I think Prof. Aishah commented a bit on that just now. Prof, maybe we can just touch base again a little bit on that.
Okay, so I think the role of GPs, I mean, of course, I'm not in the national program. I have no idea. It's not my my portfolio also, right? But I can only comment what I know in terms of the pre-vaccination assessment. So I think the patients now, if they have cancer, because you're focusing on cancer, if they go to a vaccination center, some of them may actually be turned away because the medical officers there may not know, like tamoxifen. It's okay to be on tamoxifen and get vaccinated because it's not going to cause any immunosuppression or anything like that. But there may be concerns. So I think it's very important that patients as well as their GPs have a look at the medications that they are on, you know, especially if they are on very medications that not going to cause any problems. So in this type of situation, I think the GP can actually give the, you know, the letter to certify that this person can be vaccinated. But of course, there are some drugs that are a bit more complicated. Even I am a breast surgeon, I would not sign that letter. I would send them to my oncologist. So people who are on the immunosuppressant medications like the immune checkpoint inhibitors or the CDK4/6 inhibitors, you know, this type of drugs we leave the oncologist to advise, because they need to look at the timing, when is the best time to vaccinate. And this type of patient should be given the opportunity to be vaccinated in the hospital setting. You know, I think in PPUM, what's happened is that they have given some small number of doses to be given to the patients that we can we put the patients through our system lah to get these vaccines. And I think those should be reserved for this type of patients, the patients who really need a lot of logistic issues, you know, timing, and then maybe even hemophilia patients, they would need to have their factor 8, whatever, you know. But I think for GPs, other high-risk patients that they are deemed high-risk, like cancer patients, they may be long-term cancer survivors who have already completed treatment. They are actually normal. They're probably healthier than all of us, right? They should just get their vaccination, maybe in a community setting or even in the GP setting. Yeah, so I hope that sort of clarifies the issues about cancer patients and who is suitable for vaccination, lah, especially in the community setting. Okay?
Yeah, will do, Prof. And to the doctor asking that, doctor, actually from this session, I think one of the lessons or insights that we're getting is risk assess the patient. If you think that the patient is a high risk, I think now the government is also open to the fact that, look, then don't vaccinate the patient within your setting if you think the patient is high risk and you won't be able to manage the patient. In your pre-vaccination assessment, then you assess and decide or determine that this patient is to be vaccinated in a hospital, and then let them go back into a hospital setting for them to be managed there or receive the vaccination there. I think that's currently how this is playing out, doctor.
Yeah. I think I forgot to tell you that. In that letter that we write, to the recommendations that the doctor write before they sign that letter is, where should this person be vaccinated? Community or hospital based?
Right.
Yeah, but we are still, I think it's still in the midst of organizing that SOP, I think even in PPUM. So I can imagine a lot of the other hospitals are still grappling with it. So I think we shall be patient and trust that the system works, you know. So far, it has not failed us. I think all the the vaccination centers have been doing their work very well. There've never been like bad reviews, you know, all done very systematically. So we have to trust that, you know, the system will work, and we just do our part lah, you know.
Right. Okay. So as we draw this session to a close, could I kindly ask maybe Prof. Kartini and Prof. Aishah, again, of course, thank you very much, both of you all, for taking time off on a working day to speak to all of us. And if you could leave each of us with some take-home messages, Prof. Maybe you can start with Prof. Kartini first and then Prof. Aishah slightly after.
Sorry, what is it? I'm sorry, I lost.
If you can leave us with some take-home messages.
Oh, parting. Yes, my parting points of all those things. Make sure you go for vaccine. It doesn't matter when it is. That is priority. The screening is it can be modified. The dates. I just make sure that you get the dates and the screening dates sorted out, because all the hospitals are okay. You can just tell the counter people, let's say I've got the vaccination date on this day and I've got the screening date on this day. If it's, as long as it's 6 weeks apart from the last dose, then it's fine. But if it's within, let's say, you know, some of them, let's say you get next in June, 1st June, and then suddenly you have a mammogram screening in June 30th, whereas your second dose, let's say for AstraZeneca, is going to be 3 months later. So you're in the middle of the vaccination dose, but it's fine as long as it's after 6 weeks of the first dose, because you can sort it out. But just make sure that you know when is the dates, and don't cancel the vaccination dates because that's important, right? And if you do get any axial lymphadenopathy in your patients, just follow the guideline. Just make sure you do not cause unnecessary harm, because you don't, even in a everyday work, if you find isolated lymph nodes, you're not going to biopsy, you're not going to do any harm to the patient. Just follow what you would do, or you can discuss with your primary physicians. Okay.
Okay, thank you so much, Prof. Prof. Aishah.
Okay, I think it's been a long session, I think, and maybe a lot of information has been transmitted. But I think the take-home message is always vaccinate first. We are in a pandemic. We have a duty to ourselves, our families, and our community to reach the herd immunity as quickly as possible. Okay. Some specific recommendations. I think if the patient has symptoms and signs of breast cancer, be it a breast lump, okay, or a lymph node that is not related to the vaccines, okay, please refer them on to breast surgeons as well as general surgeons as quickly as possible. The hospitals have not shut down. Our services are still running. We are still doing diagnostic investigations and treatments for, especially for cancer patients.
Yeah, it comes back to your policy just now, Aishah. You know why most of them are not coming? Because they know, okay, for example, PPUM is a COVID center. So I think most of them don't want to come, especially when there is a current what's that, the third wave going on. That's the reason why we get some of the patients cancelling their appointments. I think that's why they delay.
Yeah. So just be safe. Don't forget the 3 C's. I think our public health measures is still very important. Even though we have had our vaccinations, we still adhere to those 3 C's. Kan? I think morally you have to tell the 3 C's lah. I'm not a public health physician. So I think that's all from me. The main take home is cancer patients are different. Recognize who they are. Are they long-term survivors who are well? They should just get vaccinated. If they are on treatments and they're not immunosuppressive treatments, go ahead. They need vaccination as quickly as possible. And the last group that require an oncologist's opinion, advise them to get seen by the oncologist so that they can time their injections to the treatments. Okay? Thank you, Murali.
Thank you so much, both of you all, ladies and gentlemen. That was Professor Dr. Kartini Rahmat and Professor Dr. Nur Aishah Taib, who were speaking to you on cancer screening and COVID vaccination. Now, ladies and gentlemen, my colleague from MMA will put up the QR code for you to screen for your attendance. He'll do that right now. And that'll be on for at least the next 5 or 10 minutes or so. So feel free to take your time and screen the code. In the meantime, thank you very much for joining us. You will find the video for you to rewatch within a short time within the MMA FB pages, as well as within the YouTube channel for MMA. Thank you very much for joining us. Have a very good weekend. And if we don't see you before then, Salam Aidilfitri. Thank you so much.
Thank you. Bye-bye.